Welcome again. It's my pleasure to introduce all the friends and colleagues from TU Eindhoven for this section. This is a different sessions compared to the others, so we have all the questions at the end. So please take note of your questions because we will not have the time between one speaker and the other, but we will have a slot in the end. So the session is electrophysiological signal processing and modeling, updates from Eindhoven University in the Netherlands. And I will leave the floor to the first speaker, Alessandra Galli, with advancing non-invasive fetal monitoring through electrophysiological signals.
Thank you so much. Good afternoon, everyone. And first of all, I would like to thank the organizers for giving us the opportunity to have an entire session that is dedicated to the research that we are conducting at the TUE on non-invasive fetal monitoring through electrophysiological signals. Let's very briefly start with some numbers. First of all, approximately 2 million of stillbirths occur annually, and approximately 1 million of the neonatal deaths are linked to intrapartum complications. However, the most important number here is the fact that more than half of these negative outcomes are actually potentially preventable with timely intervention. Fetal monitoring sits right at the heart of the problem. What we know about the baby in the hours before the delivery and during the delivery itself shapes the decisions the clinicians make. Wherever to intervene, when to intervene, and most importantly, how timely to do that. And yet, the tools we rely on are not fundamentally changed in over 60 years. Indeed, as everyone knows here, the gold standard in perinatal medicine is the cardiotocography. Cardiotocography obviously has a lot of different strengths. It is non-invasive, it is widely available, and most importantly, it is familiar to the clinicians. However, also the limitations of the cardiotocography are very well known and documented. First of all, the interpretation of the CTG is visual and qualitative. Another problem is the fact that it's characterized by a very low specificity, and consequently this results in a quite high number of unnecessary cesarean sections. And another problem with the CTG is the fact that for what concerns the heart of the fetus, the only information that we have is the heart rate, while for the contraction, the only information that we have is the timing. Consequently, the information that we provide is, yes, very important, but also quite limited. This is where electrophysiological signals come in. Instead of inferring the heart rate from an acoustic bounce, we can actually record and detect the electrical signal that is generated by the fetal heart. This means that we can record the fetal electrocardiographic signal. With the fetal ECG, we can have the heart rate of the fetus with a resolution with the CTG is not possible at all, but most importantly, we can have also the entire morphology of the cardiac trace that can provide additional insights. Alongside the fetal ECG, we can also record the electrical activity that is generated by the uterus. This means that we can record the electrohysterographic signal that provide information about the amplitude of the contractions and about the frequency content of the contractile activity of the uterus. And at the frontier of the field, there is a very early but potentially very promising work on capturing electrophysiological signals that are generated by the brain of the fetus. This could potentially provide an unprecedented non-invasive window on the fetal brain development and the fetal brain activity, something that would have seemed out of reach just a few years ago. And finally, electrophysiology also allows us to study the interaction that exists between the mother and the fetus. Rather than interpreting the fetal signals alone, we can consider the mother and the fetus as a coupled physiological system. These modalities obviously are not competing alternatives, but actually they can be very complementary to each other. Each one adds something the others cannot see at all. And this altogether started to become a comprehensive picture of the pregnancy physiology. So, the question now is quite straightforward. If these are so important, why are we not already using them routinely in clinical practice? And this brings me to the next slide, that is the challenges of the electrophysiology. The first challenge with the electrophysiological signals is the fact that they are very, very weak. Indeed, the fetal ECG, for instance, is between 5 to 10 times weaker than the maternal ECG extracted from the same electrodes. Consequently, you can understand that the extraction of the fetal ECG is very challenging. Another major problem is the scarcity of labeled and annotated data. Without large and well-labeled data set, the data-driven approaches that have changed so far so many different fields and areas in biomedical signal processing still struggle to generalize in this specific field. Third problem is the variability. Signals vary substantially with the gestational age, with the maternal physiology, but also with the positioning of the electrodes. Consequently, a model that could work quite well on average struggle to perform correctly maybe on a specific pregnancy and a specific point of or specific gestational age. What would be needed here is consequently personalized approaches. And finally, even if we would be able to extract the perfect fetal ECG, the perfect fetal EEG, and the perfect electrohysterographic signal, combining them into something a clinician can actually act on is still largely an open research question. All of these are not marginal engineering challenges, but they require fundamental methodological advances. And this brings me to introduce the research directions that actually we have here currently at the TUE. In particular, our research program can be divided into 3 different pillars. The first is signals and data, because before any analysis is possible, we need signal we can trust and we can learn from. Consequently, what we try to do is to simulate them in order to having reliable signal that we can use to train, but most importantly, also to validate our algorithms. And then another important topic here is also to investigate how the gaps in the extracted parameters propagate into clinically relevant features in order to understand how much we can trust about the extracted parameter. With reliable signals in hand, the challenges shift to the extraction and the interpretation. For instance, from the fetal ECG, we can extract other information other than the traditional heart rate. But it's also important to understand how to interpret these additional clinical insights. And finally, the third theme pushes behind the fetal heart. We want to extend our research also toward the monitoring of the fetal brain activity and the fetal neurodevelopment, and also toward the investigation of the EHG signal for instance, the prediction of postpartum hemorrhage. Because we don't care only about the health of the fetus, but obviously we care also about the health of the mother. 3 teams that together span the full pipeline from the raw signals to the clinical insight. And this is actually the ambition of this session, but most importantly also the ambition of our entire research program. The presentation that will follow will take you deep in each one of these different directions, and I hope that this introduction can help you to better locate them, but most importantly to care about the research that we are conducting. Thank you so much.
Thank you, Alessandra. I call the second speaker, Suida Sankaranarayanan, for the talk on synthesis of multi-channel intrapartum fetal ECG signal with deep generative modeling.
Hello, everyone. Can you hear me in the back? Okay, perfect. Thank you for the introduction, Alessandra. Today, I will talk about my work on synthesizing intrapartum fetal ECG using generative modeling. And let's look at why we want to do this. As Alessandra already mentioned, fetal ECG gives us more information, so B2B information, and we can derive fetal heart rate and then assess it to understand the fetal condition. But there are some challenges in the availability of fetal ECG, and that's because of how we can measure. We can measure with a fetal scalp electrode invasively or abdominal electrode patch non-invasively. Each of the methods have their own pros and cons. A fetal scalp electrode gives reliable fetal ECG, however, is limited to being used only in labor, and it is invasive and inconvenient. On the other hand, the abdominal electrode patch can be used in early gestational age, is non-invasive, so as Deborah also mentioned, this can help with some mobility of the mother, but the signal suffers from low signal-to-noise ratio because of a lot of maternal interferences. So there's a need to increase the data set size, and we address the data scarcity by synthesizing multi-channel fetal ECG. And we want to do this because we're going more and more towards data-driven methods, and by performing this data augmentation, we can assist data-driven methods that use fetal ECG analysis. Let's look at some properties of the ECG wave to see how we can synthesize fetal ECG. Now, we know that the RR interval is inversely proportional to the heart rate. Let's say if my heartbeat is 60 beats per minute, then each of the ECG wave would occur at an interval of 1 second. Similarly, if my heart rate is 120 beats per minute, this interval would shorten to half a second. What we also know is that the TP segment represents the isoelectric period, and we know from literature that it contributes to the most variation in RR interval. Let's combine this information and synthesize multi-channel fetal ECG. So what if I vary the interbeat interval of input fetal ECG based on the tachogram derived from a target fetal heart rate to synthesize a multi-channel fetal ECG matching that target heart rate? Let's look at how we can adjust the interbeat intervals of a given input fetal ECG. Let's say I have this input fetal ECG, and let's say its heart rate is 120 beats per minute. So that means each ECG wave is at an interval of half a second. Let's say I want to synthesize a fetal ECG of fetal heart rate 60 beats per minute. I don't think the clinicians would be happy if this happened, but it's a hypothetical situation. So the first thing we do is segment the fetal QRS complex, and we place them at an interval of 1 second. And we use the assumption that the fetal QRS width is constant for term fetuses, and we have placed them at every 1 second. But what about this gap? How do we fill this gap? And this is where the generator model comes in. We use a generator model to generate multi-channel TP segments, insert them such that we have now altered the RR interval of the input fetal ECG. So to summarize, we have a target fetal heart rate. We compute the tachogram from the fetal heart rate. The tachogram gives us the exact interval between consecutive fetal ECG waves that I need to see in my synthetic fetal ECG. Now, based on this tachogram, I know exactly how I should adjust the interbeat interval of my input fetal ECG, and I adjust the interbeat interval of the input fetal ECG by generating multi-channel TP segments and inserting them. Let's look at an example where we use two different input fetal ECG to synthesize fetal ECG matching the same target fetal heart rate. So here we have the purple signal that corresponds to the target fetal heart rate, and the red signals correspond to the heart rates of the two different input fetal ECGs. We will focus specifically on the shaded region, and as you can see, the target fetal heart rate is lower than the heart rate of the input fetal ECG. This means we need to elongate the RR interval in my input fetal ECG. And that's what we see here. We see that the QRS complexes have shifted to the right. Also, notice how the morphology is preserved. Let's go to the second example. We see that the target fetal heart rate is higher than the heart rate of the second input fetal ECG. So that means we need to shorten the RR intervals of my input fetal ECG, and that's what we see in our synthesized signal. We see that the QRS complexes have now shifted to the left. And what I really want to stress is that the TP segment is the only part that we are altering. That means, in principle, we are preserving the fetal QRS morphology. And how do we validate this in a quantitative manner? And for this, we used signal quality indices proposed in literature specifically for fetal ECG. So to simplify, if my standard deviation of my input fetal ECG is X, then I expect the standard deviation of my synthesized fetal ECG to be around the same value. And that's what we try to compute when we have different signal quality indices. And we also calculated the correlation coefficient, and we see that it's high for most of these indices. Additionally, we proposed fetal heart rate-based indices because we want to compare the statistics of the estimated fetal heart rate from our synthesized fetal ECG. We want to see if the statistics of the estimated fetal heart rate match with the statistics of the target fetal heart rate that we wanted to match in the first place. And we also see that the correlation coefficient is pretty high. To conclude, we synthesize multi-channel fetal ECG by altering interbeat intervals of an input fetal ECG based on the tachogram derived from this target fetal heart rate. And we adjusted the interbeat intervals by inserting TP segments generated from a learned generative model. We addressed data scarcity by expanding data set size significantly, and also we validated that the fetal QRS complex morphology was preserved in the synthesized fetal ECG signals. Thank you for your patient listening, and I'm happy to answer any questions during the discussion or maybe later during the break. Thank you.
Thank you, Sveta. Thank you, Irene. Next speaker is Bushra Hunlu. The talk on the impact of missing FHR value on the accuracy of heart rate variability features.
Can you hear me? Can you hear me? Okay, maybe this is better. No, it's right. Okay. Okay. Today I will present an ongoing study investigating how signal loss affect the fetal heart rate indices from the indices derived from the CTG recordings. Some babies suffer from the fetal growth restriction and grow more slowly than the others. The only current treatment is to deliver the baby. But however, deciding when to do this, it is difficult because delivering too early increases the premature-related complication, and whereas delaying the delivery increases the risk of the fetal compromise. To support this decision, clinicians monitor a fetal heart rate with the cardiotocography and use the fetal heart rate matrices. But the signal loss is the frequently occurs during the fetal monitoring due to the fetal movement, uterine contraction, and transducer displacement. Here's an example of the signal loss in the CTG, because it may influence the estimation of the fetal heart rate indices. It is important to evaluate how robust these indices are to different levels and the structure of the missing data. Our aim is to evaluate how signal loss affect fetal heart rate indices and compare the robustness of these indices across different signal loss percentages and the signal loss structure. I will explain our method in the three parts. First, data preparation, signal loss simulation, and the robustness assessment. In the first part, in data preparation, first we use the scalp electrode CTG records. Continuous 3-minute CTG segments are without the signal loss were extracted from the signals, and these segments were used to calculate the baseline values of the investigated fetal heart rate matrices. We first focus on the time domain fetal heart rate indices, mean fetal heart rate, short time variation, variance of fetal heart rate, long-term irregularity, delta, and the interval index. In the next part, in the signal loss simulation, signal loss was artificially introduced with the non-values to mimic the realistic signal dropouts observed in the clinical CTG recordings. Randomly distributed signal loss, similar to measurement noise and the dropouts, and the continuous block, resembling the probe displacement or the temporary signal loss. And we control this structure with the signal loss percentage and the signal loss fragmentation. The parameters, I call them the C. And for each condition, to accurate the randomness of the signal loss location and the block structure, we repeat this analysis 100 times. After introducing the signal loss, and then we calculate all matrices again from these segments. In these plots, fragmentation level is 0.70, and then you can see the different signal loss percentages that we introduce into the signal. And also we varied both the percentages of the signal loss from 5 to 50% in the same fragmentation level. And also we varied the structure of the signal loss from 0 to 1. The 0 means the randomly distributed signal loss, and the 0 is the continuous signal loss block. From the 0 to 1, signal loss is going from the random to the less random. And this plot, the signal loss is 25%, and you can see the different level of the fragmentation levels. In the robustness assessment, we focus on the mean absolute error, which quantifies the average magnitude of the deviation introduced by the signal loss, independent of the direction of the change. So we calculate the absolute difference between the baseline value and the value under each signal loss condition. And then we average across all segments and the repetition for each combination of the signal loss percentage and signal loss and fragmentation level. I will show the first results, the impact of the different signal loss percentages, fragmentation on the fetal heart rate time domain indices. You can see in these heat maps and line plots the overview of the mean absolute error across signal loss and the fragmentation level. You can see in the x-axis the fragmentation and the signal loss on the y-axis. And STV and the variance of the fetal heart rate errors increase with the signal loss, especially for the long continuous signal loss blocks. And the mean fetal heart rate remain relatively robust, with high errors mainly under the high and highly clustered signal loss conditions. And overall, the signal loss structure slowly influenced the error, even at the same signal loss percentages. In the LTI delta, were affected by both signal loss and the fragmentation. And the largest deviation were observed on the continuous missing data pattern, C equals 1. And the interval index was less affected by the signal loss than the other variability indices. Next, we look at whether the signal loss sensitivity depends on the baseline level. So the STV is the clinically relevant CTG parameter, with the low values around the 3 and 4 milliseconds, used as the important threshold in the fetal heart rate monitoring. One question was whether the effect of the signal loss depends on the baseline STV level. To investigate this, we analyzed two STV ranges, STV below 4 and the STV is between 4 and 6. And the mean absolute STV error increased with both signal loss and the fragmentation in both baseline STV groups. However, the low STV group, smaller than the 4, consistently shows smaller absolute error than the other groups. So in the conclusion, mean FGR was relatively robust, but STV, variance of the FGR, LTI and delta were more sensitive to the signal loss, especially with the continuous signal loss structure. And the signal quality should not be assessed by the missing data percentage alone. Also, the signal loss structure is important. And although low STV range recording showed the smaller absolute error, clinical decisions should not rely on the signal CTG recording, and single completeness and the morphology should be considered when interpreting the CTG metrics. Our future plan, we also want to evaluate the frequency domain and nonlinear metrics. And thank you for your attention. I will happy to answer.
Thank you. Calling the next speaker, which is Giulia Acquaviva. Her talk is titled Toward Non-Invasive Fetal Brain Monitoring Through Multimodal Integration of Electrophysiological Measurements.
Thanks for the introduction, and hello everyone. So in my presentation, I will focus on the integration of electrophysiological measurements acquired using different sensing modalities with the aim of non-invasively monitoring fetal brain activity. So, as you all may know, perinatal neurological complications represent a major cause of neonatal disability and developmental disorders. And these conditions are mainly due to an insufficient transfer of oxygen from the maternal to the fetal circulation through the placenta, which causes asphyxia or hypoxia. Among all these complications, the most severe is hypoxic ischemic encephalopathy, which can result in death or severe disabilities in 60% of affected fetuses. The incidence of HIE is estimated at 1.5 to 2.5 cases per 1,000 births in high-income countries. However, this rate substantially increases in the case of low and middle-income regions, reaching up to 20 cases per 1,000 births. Therefore, the early identification and diagnosis of impaired neurodevelopment is fundamental, as it may mitigate these numbers and enable prompt treatments. Currently, fetal brain activity is monitored using standard imaging techniques. However, these methods are expensive, they require specialized operators, and they can raise concerns regarding their safety. As a consequence, they are not part of routine monitoring, especially because they are unsuitable for frequent and labor-specific applications. In addition, 2/3 of the global population, especially in low and middle-income countries, lack access to medical imaging. Therefore, a promising alternative to imaging techniques in order to monitor fetal brain activity is the use of fetal electrophysiological measurements, which are cost-effective, safe, they allow for frequent monitoring without requiring specialized personnel, and they can be applicable to extraambulatory settings. Despite these potentials, the application of these measurements to fetal brain is still limited. In fact, extracting reliable neurological information from electrophysiological signals is challenging, as fetal signals have very low amplitude and are usually corrupted by noise. In addition, the lack of gold standards for measuring brain activity and the inaccessibility of the fetal scalp complicate the clinical validation of these methods. Therefore, with our research, we would like to develop novel technologies that can contribute to overcome the current limitation in fetal brain assessment by using electrophysiological measurements, and then contribute to advance the state of the art. In particular, we have two main objectives. First, we want to assess fetal neurodevelopment by deriving indirect indicators related to brain maturation, especially from fetal ECG. Second, we want to develop a method that can reliably extract fetal EEG from transabdominal signals. So, to meet the first objective, we will first acquire electrophysiological, inertial, and ultrasound data by performing two parallel data acquisition. The first one is a longitudinal data acquisition, and it will be conducted at Maximum Medical Center in Eindhoven under the supervision of Professor Van Laar. It will include 5 different measurements, starting at 18 gestational weeks and repeating at 4-week interval until the 38th week of pregnancy. And in this case, only healthy fetuses will be measured. The second acquisition is transversal, as it will include 1 measurement within 35 and 37 gestational weeks. In this case, the population will comprise both healthy and neurologically impaired fetuses. The data will be acquired at the University of Parma under the supervision of Professor Dall'Asta. So all these available data will be then analyzed to derive indirect indicators that can describe brain maturation, such as fetal heart rate variability, movements, breathing, and behavioral states. And from these indirect indicators, we will then extract key features that describe their characteristics to create a model of neurodevelopment. In fact, we expect those features to vary, to evolve in a certain way throughout pregnancy. Therefore, they will serve as a proxy for neurodevelopment. For what concerns the second objective, we will use 2 types of data, in silico and in vivo data. In silico data will be generated using a simulator modified to synthesize fetal ECG, maternal ECG, fetal EEG, and noise under variable conditions, for instance, with different noise level, with different fetal positions. In vivo data will be acquired at Amsterdam UMC under the supervision of Dr. Bakker. And we will have one single measurement during labor with an acquisition setup that includes an 8x8 grid of wet electrodes placed on the maternal abdomen and a scalp electrode placed on the fetal scalp, which will provide the reference signals for a total of approximately 20 pregnancies. Right now, for this acquisition, there is an ongoing feasibility study with an initial research setup. With this data, we would like to then develop a multi-step algorithm that is able to extract fetal EEG signals from transabdominal recordings by removing all the components that interfere with the signal and then corrupt it. The performance of this novel method will be then first tested in silico and then validated using in vivo data. So, to conclude, we want to favor the integration of the proposed approaches into clinical decision support systems and wearable devices that can be easily applied in homes, hospitals, and low-income settings, facilitating then timely interventions and improving pregnancy outcomes globally. So with our research, we want to pave the way for exploiting the full potential of electrophysiological measurements, in this case for fetal neurological assessment, so that we can enable a continuous and an accurate monitoring of fetal health. Thank you for your attention.
Thank you very much, Julia. Next speaker is Milad Mazaheri. And his presentation is on a comparative study of intrapartum and postpartum electrostereography activity towards prediction of postpartum hemorrhage.
Hello everyone. Today I will present our study titled Comparative Study of the Intrapartum and Postpartum Electrohysterography Activity Towards Prediction of the Postpartum Hemorrhage. So, postpartum hemorrhage is the leading cause of the maternal mortality worldwide, accounting for an estimated 50,000 deaths annually. And electrohysterography non-invasively measures the electrical activity of the uterus by using the electrodes on the abdomen. And it is very well studied during the intrapartum, but extending its use to the postpartum period can provide a valuable source of information for the early detection of the postpartum hemorrhage. So we hypothesized that intrapartum and postpartum EEG signals differ in the measurable electrophysiological characteristics. So our objective is to quantify these differences and identify the most discriminative features using the machine learning classifications. So this figure illustrates the periods that we included in our analysis. For the intrapartum, for the labor, we have around 40 minutes before the live birth. And for the stage 3, it starts from the live birth till the placenta out. It's a variable period, but on average we have 20 minutes. And we have 20 minutes for the post-placenta. But clinically, stage 3 and post-placenta are considered postpartum phase. We collected the data using a NEMO device from 4 bipolar channels, and then we extracted the EEG from them for this study. And the data set started with 446 patients, and then we excluded the postpartum hemorrhage cases and only included the spontaneous vaginal deliveries. And for the stage 3, we considered the duration between 10 to 30 minutes and removed the poor quality and noisy recordings. And the final cohort is 22 patients. So we pre-processed the 4 EEG channels. We annotate them using a developed tool. And for the intrapartum part, we annotated the contractions based on artifacts, but for the postpartum parts, we annotated only the artifacts. And then we concatenated the annotation to make 4 continuous epochs labor contraction, labor baseline, stage 3, and post-placenta. And then we decompose to 3 frequency bands, slow wave, fast wave low, and fast wave high. So from 4 channels, 3 frequency bands, and 4 epochs, we extracted a set of time domain, spectral, and nonlinear features to classify them to these 4 epochs to find out about the discriminative features. We started with the 4-class classification, and we had a moderate performance. But as we can see, the model is struggling for stage 3 and post-placenta. So can we distinguish a stage 3 from post-placenta? Are they distinguishable between parts like labor? So that's why we look at the binary classifications on the right. As we can see, stage 3 and post-placenta are basically indistinguishable. And then we decided to consider the labor contractions or labor baselines together as intrapartum, and stage 3 and post-placenta together as postpartum. And then they are clearly distinguishable with the high performance. So, and then we run our machine learning models on different combinations of the channels and 3 frequency bands. And we had the best performance for the fast wave high across all the channels. And here we have the SHAP summary plot. So it shows how much each feature pushes the model decision towards the intrapartum or postpartum. So the samples, the values closer to the center has no effect on the classifications. And when they are far from the center, it means they have a strong influence on pushing towards one class or the other. So features like energy-related features like Tiger-Kaiser energy, we have the higher values for the intrapartum part on the left and lower values on the right side for the postpartum. And for the features like sample entropy, we see the lower values on the left side for the intrapartum and higher values on the right side for postpartum. So to conclude, results indicates that stage 3 and post-placenta are not 2 distinct electrophysiological states after live birth. And intrapartum EHG is characterized by high energy and low entropy, reflecting the coordinated uterine activity. And the postpartum EHG shifts toward the lower energy and higher entropy. So postpartum EHG signals weakens and becomes more irregular. So throughout predicting the postpartum hemorrhage, these discriminative features are the markers of the coordinated uterine activity. And in future also we can consider them for the PPH cases and a study on the postpartum hemorrhage cases, and maybe with the larger cohort. And of course a bit of blood. And thank you for your attention. And if you have any input or suggestion, please reach out. Thank you.
So I'm calling the last speaker of the session, which is Giulio Steide, with a talk on does maternal respiration drive fetal-maternal cardiovascular coupling?
Thank you for the introduction. Good afternoon. Where is my presentation? Here it is. Okay. As you all know, the maternal and fetal cardiovascular systems are separate but also deeply interconnected. And of course, they interact with each other. And we also know that some of the most impactful pathologies in pregnancy are somehow related to problems in the interaction between the maternal and the fetal cardiovascular systems, talking about pathologies such as preeclampsia, fetal growth restriction, and asphyxia. And that's why we believe it's so important to being able to model the interactions between the 2 systems. And one of the ways that we have to do so quantitatively is to see to quantify the interactions between the maternal and the fetal heart rates. There is some literature on this phenomenon, which is called maternal-fetal cardiac coupling, which could be useful for early prediction of some of these pathologies. But there is still a lot that we don't know. For example, what physiological mechanism drives this phenomenon? Is there some other physiological variable involved? And one of the hypotheses that was risen a few years ago is that maternal respiration could act as a common driving force, and so maybe behind this interaction. We don't know whether this is true, whether maternal respiration influences both the maternal heart rate and the fetal heart rate, or maybe it just modulates the maternal heart rate, which in turn modulates the fetal one. We already know, of course, about the connection between maternal respiration and the maternal heart rate variability, which is the respiratory sinus arrhythmia, while the interaction between the respiratory activity of the mother and the fetal heart rate variability is what we wanted to assess in this study. And to do so, we used a data set of about over 300 abdominal non-invasive ECG recordings from healthy pregnancies at middle second trimester. And we extracted from the abdominal ECG the ECG-derived respiration, the beat-to-beat fetal heart rate, and the beat-to-beat maternal heart rate. And then we estimate coupling by looking at metrics related to the concept of Granger causality, which basically asks if the past of one time series A, that could be, for example, respiration, help us predicting the future of a different time series B, that could be the fetal heart rate, then A, Granger causes B. And then we assess the significance by comparing the values that we get from the real data to some surrogates data that have all of the interesting statistical properties, but decoupling. And so this is an example. We start from the abdominal ECG. Here I'm showing just one of the 6 channels of the acquisition setup. And as it's already been said, from the abdominal ECG, we can get beat-to-beat fetal heart rate. Of course, much easier beat-to-beat maternal heart rate, but also the respiratory activity, as this modulates the amplitude of the ECG, and particularly the QRS complexes of the maternal ECG. And from these time series that we can extract, what we did was to compute these metrics that quantify the concept that I introduced before, the concept of Granger causality, which are directed coherence, partial directed coherence, generalized partial directed coherence, which live in the frequency domain, so we can also separate the contributions on the frequency axis. And these metrics also work with stationary signals, so short-term interactions, we're talking about 2 minutes period. Nothing to do with the circadian rhythms and behavioral states, which could also be interesting. So jumping to the results, what we observed is, well, first of all, we can confirm something which was already known. The maternal heart rate is modulated by respiration, as it is for all adults. But more interesting, the maternal respiration also modulates the fetal heart rate. The effect size is much smaller, but it's still highly significant. We see an interaction that goes from maternal respiration to the modulation of some fast oscillations in the fetal heart rate. While if we look at the interactions between the maternal heart rate and the fetal heart rate, when also respiration is taken into account, we cannot see any significant interaction in the short term anymore, at least in this cohort in the second trimester. So this tells us that in the short term, maternal fetal cardiac coupling, at least in this gestational age, which we investigated with this middle second trimester, is largely driven by maternal respiration. So maternal respiration modulates both the maternal and the fetal heart rates. And so this respiration must be taken into account when we measure both heart rates, because they're modulated by a common source. The strength of this interaction is quite modest, but this is expected. So this work provides some, we believe, some groundwork for future studies, clinically oriented studies, because there is still a lot that we don't know and that we would like to find out. So how does it change during gestation at different gestational ages? Does it grow stronger? Does it fade away with the evolution of the systems? And also, we would like to integrate some paced respiration protocols to try to assess this in a more direct way, and possibly more interestingly, to integrate additional physiological variables. We suspect that the arterial blood pressure of the mother might be another big player in this system, and also the velocity of the blood flow of the umbilical and uterine arteries. And then finally, assess whether indeed, in case of like preeclampsia and intrauterine growth restriction, this interaction is impaired, or does it change in some way that we can use to predict the onset of the pathology. So thank you for your attention. If you have any questions, here.
Thank you all for the presentations. And so it's time for questions. Any questions from the audience? Yeah.
Yeah, I was interested in the EHG study because presumably this corresponds to EMG studies in skeletal muscle and whatnot. And I guess I have two questions. First of all, normally when one analyzes EMG to try to predict the output force, you rectify it and then low-pass filter it before performing the analysis. So I'm wondering why you looked at exactly the raw EHG rather than the rectified EHG.
I didn't look at the, can you hear me? Okay. I didn't look at the raw EHG. We used the bandwidth to filter we have some low frequency nodes in the EHG already. So we used the different bandwidth, and also we didn't look at only one bandwidth. As you could see in those slides, we tried 3 bandwidths for that. One from 34 to 1 hertz, one to 1 hertz to 2 hertz, and the other one 2 to 3 hertz. And when we look at the literature, there isn't like a reference for it. Everyone uses a different range for that. But here also I tried to use 3 bandwidths if we can see something different in these bandwidths. Also, I think in the higher bandwidths to fast wave low and fast wave high, maybe we have some information from like heart rate harmonics from the maternal or I think that's something I should look into it. Yeah. Yeah.
So the other question I have is that the EMG you pick up depends to a large effect on the orientation of your electrodes with respect to the muscle fibers. So what do you know about the fiber orientation of the muscles with respect to where your electrodes are?
Fiber orientation, I don't really know.
Okay. Because depending on the orientation,
yeah,
you get a very different signal. If you're oriented, I mean, ideally you want your differential electrodes to be oriented parallel to the...
Yeah, we have 4 channels for it, and we tried to include all of them, and then to see what the models decide about it. And here we had the best performance for the combination of all of them. But usually they consider it from fundus to cervix. But I don't think it's the best all the time. They say it pushes from the fundus to cervix. That's true. But also I think we have the multiple pacemakers. It's not only one pacemaker from fundus to cervix. Yeah.
Okay, thanks.
Thank you for the question.
Other questions? What's the order? I don't know. Okay. You first, it seems.
It gave you more steps for you and your heart rate changes. First, I want to commend you all. It was just going to be so exciting to find out what the results are that you're getting from all your different projects. It made me wish I could go back and be a student, or not a student, a postdoc with you guys. But I was wondering, just for the last question, it's a recency, the last presentation, because it's the one that's right in my mind. Giulio, you had mentioned on purpose, you didn't want to have sleep states be confounded in the kinds of things you were looking at. Would you have a guess that if you only looked at a fetus when he or she was in quiet sleep, that you might get a little bit more of a signal about the relationship with maternal respiration, or do you think it probably doesn't matter about the fetal sleep state?
It was the 5th month of gestation, so we couldn't really see any behavioral cycling. But if I had to guess, I would say that during quiet sleep, it's probably much easier to see some kind of synchronization, because during active sleep, you have big accelerations, and that kind of confound also frequency domain analysis, because that goes in the very low frequency domain, while a more stable baseline, as it is during quiet sleep, would probably make it easier to detect. I'm not sure whether the interaction itself would be stronger, but I would have to guess easier to catch with these methodologies, at least.
Thank you. I have a question about maternal respiration affected fetal heart rate as well, directly. That sounded really interesting. So would you be able to clarify a bit in which direction maternal aspiration or exhale changed fetal heart rate? Increase or decrease in that way?
That's a very interesting question. I don't have an answer to that, because that's not something that we actively saw, also because the maternal respiration was estimated by the movement of the electrodes on the belly.
Oh, right.
So we don't have nasal flow. We don't really know exactly when it was inspirating.
Yeah, I'm really interested in the potential mechanisms.
If the breathing comes from the diaphragm or from the chest. So that's,
right.
I really don't have an answer to that, but I would like to.
Okay, thank you. In adults, so when we aspirate? So
we have a similar doubt here.
So decreased intrathoracic cavity makes the maternal heart rate goes down, right? No, increased. So if it affects fetuses, so maternal oxygen saturation cause kind of chemoreflex. That might be one potential mechanism. So that was interesting.
You mean like the compression could cause some kind of chemoreflex in the fetus, or maybe the umbilical cord as well?
Yeah. So some gas exchanging through a placenta might affect fetal heart rate potentially. The fetus has kind of very sensitive chemoreceptor. So I'm not sure in healthy mom's respiration effect in that way, but that might be a very interesting point to investigate.
Yeah, thanks.
Other questions? Yes.
This is regarding the last one. Do you think hemoglobin levels in mother would also add value to quantifying or at least establishing the correlation? The hemoglobin levels. This is for the coupling. For the last presentation, when you are trying to establish the relation for placental perfusion, the hemoglobin level of the expecting mother, do you think that would add value in quantification? Because naturally, there is a correlation between ability to absorb the oxygen and hemoglobin levels.
I don't know much about this relation, so I would love to
because it's
learn
possibly
more about
not a problem, because low hemoglobin levels are possibly not the problem in the West. So maybe just try to consider hemoglobin level of mothers as a factor of consideration.
Okay, thank you for the suggestion. I'll look it up.
Other questions?
Thank you. May I switch to Giulia? My question was about the quality of the data you can obtain, because you said that the EEG is measurable since few gestational weeks. So if I if I understood correctly, 18 weeks on. Is it correct?
Can you repeat, because I cannot hear you very well?
Yeah. You reported that the EEG can be measured with the method you show in earlier gestational week. Was it correct?
Yeah, actually, not really. Can be measured a little bit later, around 24 weeks.
Around, sorry?
EEG, you said.
EEG.
EEG. Yeah. Yeah, the measurements, the first measurements starting at 18 weeks is about fetal ECG. So the fetal EEG will be acquired during labor with the scalp electrode.
Okay.
Yeah.
So because I got confused with that, it was, and instead the quality of the signal you are able to obtain is enough to be processed, to be ready for advanced processing, or do you have to pre-process? And
So the thing is that this is like the presentation is the plan, is the dream. So we would like to have a very nice signal, but we still don't know. There is very few evidence in literature, but we think that if we could arrive to have a proof of concept of the extraction of fetal ECG from transabdominal recordings would be already very nice. We already started with in silico data because we have this simulator. So we're doing some trials with blind source separation techniques, and we are working on it. So I cannot tell you very much about this right now, but yeah, we aim for the best.
Okay, thank you, Giulia.
Thank you.
And connecting to this, do you think you will have the chance to compare your method with magnetoencephalography, fetal magnetoencephalography?
Yeah, we can do that. I mean, yes, with available data, we would like to do that also to show that these measurements are reliable and can be can take the place of imaging techniques, which have a lot of problems, as previously said.
Okay, thanks. There was a question there.
Thanks. Thank you for this interesting presentation. I would like to ask, based on the postpartum hemorrhage presentation, if I understood your presentation correctly, you excluded the cases with previous PPH.
PPH, yeah.
And I would like to ask if it so, how did you account for the factors that may influence the risk of major bleeding, such as episiotomy or third-degree lacerations or the use of oxytocin?
Could you repeat the question? Sorry, I couldn't hear you.
So if I understood right, you excluded the cases with the previous PPH.
No, we didn't exclude the cases with the PPH.
Okay, but however, how did you account for the cases if there was some risk factor for big bleeding, major bleeding, like episiotomy or lacerations or the use of oxytocin? Did you done anything for those cases?
Yeah, I get your point, but in this study we just tried to call the patients without the PPH as a healthy one. So we include them and excluded the cases they had a PPH in the postpartum part. And there are many factors or co-founders for the PPH. Maybe we couldn't consider all of them in this study. Otherwise, we didn't have any data or patients to study and work on it. So after all those exclusion and inclusions, we had only 22 patients. Maybe that's enough for a preliminary study, but if we want to find out about the normal values for the patients without the PPH or with PPH, we need a bigger data set.
So, yeah, thanks.
We have 5 more minutes for questions. Are there any other questions? Yeah? Also have one.
So I was interested in the study where you were generating simulated variability. It wasn't clear to me how, as I understand it, what you did is you essentially changed the inter-RR interval by either... Okay.
Yeah.
There we go.
Yeah.
Either by shortening it or lengthening it.
Yeah.
So I guess my question is how did you determine both the frequency content and the amplitude content of the inter-RR interval
Yeah.
data set?
So we generate TP segments, and so we trained on normalized TP segments that we used to train the generator model, and now we have the learned generator model. So we need to scale this to more or less match what the noise characteristics in the input fetal ECG. So if I'm altering the RR interval between fetal ECG at time step T1 and T2, whatever is the noise characteristic between T1 and T2 ECG wave, I calculate the mean and standard deviation and then scale my generated TP segments. And then we do cross-fading to ensure we don't have too many transient effects. But I do agree that it would be better to have a conditional sampling, because right now we're doing unconditional sampling on the generator model. It would be better to actually incorporate the morphology of the starting ECG wave at T1, or maybe both, and then we can do some conditional sampling. I think that would be nice. Yeah.
Thank you.
Any other question?
Thank you for your presentation.
Yeah.
I have a question about maybe you already mentioned about this, but are you planning also to act on the different waves of the ECG when you are moving from one fetal heart rate to another, as for example accounting for the nonlinear relationship between the RR and the QT intervals?
Yeah, I did consider that, and then what we did is like we are only manipulating the end of the T wave and the start of the P wave, but what you're saying is really the QT interval is from the Q till the end of the T wave. So because we are manipulating only between the end of T wave and the start of P wave, we are really not altering the entire ECG itself. But it again goes back to what I previously said. I think to go a step forward, it would be better to do a conditional sampling, which we did not do as of now. So I think that will also make it clear that we are addressing what you just pointed out. Yeah.
Thank you.
Yeah.
Other questions? Yeah. Very last question from myself, and then we can switch to that. So it was for Irene. Was the fetal ECG you presented and annotated, or made annotated by the experts, was obtained from invasive recordings or from non-invasive?
Non-invasive.
Non-invasive. So it was your own algorithm, or?
Yes.
Okay.
We used, for the fetal ECG extraction, we used an algorithm that has been previously designed within our group by Alessandra Gali.
Okay, so do you think that it could be affected by the kind of algorithm you're using for the extraction, I suppose?
Yes.
Okay.
Maybe yes. Yeah, but for now, so we can see that the from our extraction, we can clearly see the P and the T waves. On this data set, we have also a fetal scalp electrode. So we can use this kind of as we can see that there are P waves and we see them also non-invasively. So we know that our algorithm, it's not making things up. So sometimes we don't see a T wave, but it doesn't invent waves. Yeah.
No, I just wanted to. It's a source separation algorithm. It's not a generative algorithm, so we don't really expect for it to fill waves and invent stuff.
Okay. Thank you so much. So thank you to all the speakers of this session.